the choice of first-line treatment sets in motion a sequence of events. It's, of course, when we start with, let's say, an oxaliplatin-based regimen, we want to use an irinotecan-based regimen in second line. And the choice of the biologic agent is determined by molecular factors, RAS and BRAF, mutation analysis, MSI now with the immune checkpoint inhibitors, but also sidedness. We know that left-sided tumors have a chance to respond to EGF receptor antibody therapy, and I consider them, for most patients, standard of care. So cetuximab or panitumumab added to backbone chemotherapy, either a chemotherapy doublet or even a chemotherapy triplet. And then we would use bevacizumab in a second and potentially even in a third line setting with bevacizumab beyond progression. So these sidedness questions really determine, in a way, the sequence of events and how many lines of therapy we have available. So in a right-sided tumor, for instance, even if it's RAS and BRAF wild type, I would not use an EGF receptor antibody in first line. I might, however, consider this EGF receptor antibody after failure of all standard therapy, which would then include regorafenib and TAS-102, because there are probably and very likely patients with right-sided tumors that do benefit from EGF receptor antibody therapies. We have not been able to characterize those patients yet, but I would not withhold treatment, when a patient's backed against the wall from a patient with a right-sided tumor when I believe EGF receptor antibodies have not been used before.
Clearly, what we have learned in the past 20 years is that metastatic colorectal cancer is a very heterogeneous disease, depending on which are the most important and relevant genetic alterations that drive tumor development and progression, depending also where the tumor arises, if it's localized as a primary tumor in the right side or in the left side, because these are usually accompanied by different genetic alterations, and so different potential genetic drivers, and therefore different potential molecular targets for specific therapies. Therefore, before first line for metastatic disease, what we do is try to characterize as much as possible the genetic makeup of the tumor in the particular patients. In large comprehensive cancer or academic cancer centers, usually by next generation sequencing approach, this is achieved. But in most cases in the big countries in Europe, most patients before starting first line are characterizing their tumor at least for the presence of mutations in the KRAS and NRAS genes, in the presence or absence of mutations for the BRAF gene, and more recently, all patients are also characterized for DNA repair deficiency or proficiency. Therefore, macrosatellite stability or macrosatellite instability is measured in these patients. So to summarize my answer, I will say that at least for the large cancer centers in Europe, RAF mutations, MSI status, primary tumor location, and also HER2 gene amplification status are routinely measured before starting first-line treatment. And these define what is our choice. Because usually what we decide to use as first line is a chemotherapy doublet, like FOLFIRI or FOLFOX, that is combined with appropriate biologic agent, such as an anti-angiogenic drug, most likely bevacizumab, or an anti-GFR monoclonal antibody for RAS and RAF wild type patients, mostly if they are with a tumor localized in the left side of the colon, with cetuximab and panitumumab. For MSI-high patients in Europe, and this is different from what happens in the United States, unfortunately, PD-1 or PD-L1 inhibitors have not yet been registered by our authority, by EMA, and so we cannot use them outside clinical trials, either in first line or in subsequent lines. But I'm sure after the presentation at the ASCO 2020 annual meeting of the results of the Keynote 177 study, in which pembrolizumab showed a very important progression-free survival advantage over standard chemotherapy in first line of MSI-high patients, this will shortly change in Europe. And therefore, more and more, in my opinion, MSI-high patients will be treated with immunotherapy even in first line in Europe. Regarding BRAF mutant patients, after the BEACON data were reported at the end of last year, clearly what is known now is that for second and third line BRAF mutant patients, a combination of BRAF selective inhibitor encorafenib and cetuximab, the anti-EGFR monoclonal antibody, is the primary options for second line. Whereas what is the primary option for first line for BRAF mutant patients is still under debate, unless this patient have an MSI-high status, in which I think immunotherapy plays a major role. After first line, all patients are candidates for second line. However, unfortunately, a proportion of them after progression are not fit for second line. What happens in general in Europe is that on the average, between 50% to 80% of patients after first line failure are available and are suitable and fit for a second line treatment.
The decision for first-line treatment is really the most important decision you make for your patients. I think it is absolutely critical to understand the molecular makeup. You need to know VAS status, BVAF status, microsatellite instability, because that will determine your choice of first-line treatment. For VAS wild type and left-sided colon cancers, it would be for us a combination of chemotherapy with an EGF receptor inhibitor. I personally like FOLFOX with cetuximab. If this would be a mutation of KRAS, you cannot use an EGF receptor inhibitor and you would use bevacizumab. Here it comes to a decision how aggressive you want to be with your chemotherapy backbone. If a big tumor burden, borderline resectable, young fit patients, I actually would consider a modified FOLFOXIRI regimen. I do the same for right-sided colon cancer with wild-type RAS, because right-sided colon cancer are significantly associated with poor outcomes, and here I actually step up with aggressiveness with the chemotherapy backbone.
An important issue for treatment of first-line metastatic colorectal cancer patients is which is the best chemotherapy backbone. In my opinion, and according to the guidelines, like the European ESMO guidelines, a chemotherapy doublet should be offered to all patients, regardless of age, unless these patients are unfit for therapy. A major question is, do we need to intensify doublet chemotherapy, either FOLFIRI or FOLFOX to FOLFOXIRI? And the answer is, in some patients that are fit, especially with bad prognostic characteristics, maybe the choice of FOLFOXIRI as backbone for first-line treatment is a good choice. In our practice, we usually use FOLFOXIRI instead of FOLFIRI or FOLFOX for fit RAS mutant patients in which we would like to have a rapid tumor shrinkage. And in this case, we combine with bevacizumab. And also for fit BRAF mutant patients, for which we require an important tumor shrinkage, we use FOLFOXIRI. In these cases, we don't know if FOLFOXIRI bevacizumab is better than FOLFOXIRI alone, but in our experience, FOLFOXIRI as chemotherapy backbone, as compared to FOLFIRI or FOLFOX, is reserved to fit patients in which, with RAS or RAF mutation, we need a rapid and sustained tumor shrinkage.